So what about something you might, obviously we're all using this regimen. Any tips you want to share, any kind of special issues that have come up so far in your treatment with this new paradigm? Actually, this is a pretty quick change. It's only 6 months ago. You weren't doing this and now we are. So have you learned anything in those 6 months?
Well, I think the important thing to learn from the trial first is the adverse event profiles were only slightly different between the placebo and the Durva arm. I think that, as you were saying, when you're going for a curative endpoint, you're willing to sometimes put up with worse toxicities. The toxicities, as reported, were not significantly worse. So that I think surprised a lot of people.
Yeah, I think it did.
And I think right now, the same guidelines that people are using to deal with any of the checkpoint inhibitors and their toxicities would apply. I have not heard of any unusual effects in this cohort as opposed to those getting this treatment for metastatic disease.
So putting you on the spot, let's say you have a medical oncologist that wanted to give, their standard was to give 4 cycles of chemotherapy, and they're unconvinced by this data so far. What would you say to that medical oncologist?
So you're saying give the 4 cycles with the radiation rather than giving Durva?
Yeah.
Saying I've been doing this since I was a boy or a girl or whatever.
This one paper and...
You know, I would push for using the Durva once we have survival data and longer progression-free survival. I would even push harder.
Okay. Jyoti, anything you've learned in the last 6 months of doing this?
I think this study is certainly singular. I mean, it changes the paradigm, but getting back to something that Wally mentioned, I mean, there is now an accumulating body of data to suggest that there is synergism between radiation and immunotherapy. And we are seeing these subsets do better than ever before. And so although it's one study, it kind of stands on the shoulders of a large body of data that really supports this concept.
Again, it's, I think one issue that has come up already is what do you do when somebody has pneumonitis? I was faced with that, and we have 2 competing causes of that. Easily it could have happened from the concurrent chemotherapy and radiation, but also a patient was on immune checkpoint blockade as well. I think what you have to do, actually the treatment for both is the same.
Right.
So it made it kind of easier, but it was quite a dilemma.
Yeah.
The other question that came up with...
And the question is whether you'd stop the immune checkpoint.
Right.
That's the toughest part.
That was the exact question that came up. The one interesting thing, though, is a growing literature that the patients often with the most profound benefits from immune checkpoint blockade that have very serious toxicities have had long-term benefit from just a single dose of these drugs. So it may be that one of them to prime the immune system in a way to attack the cancer and priming it in such a profound way that pneumonitis came out, it may be that the one dose is good enough, but I mean, that's a unique problem that can come up here.
I think it's interesting. Last week I had 2 cases in which I had patients who had been treated in the community with Durva after chemoradiation. And in both of those patients, there was pretty significant pneumonitis, which was closer to the radiation. And so again, we had sort of 2 competing causes. But both patients came, I think, because of the oncologist they were seeing were feeling so guilty about holding the Durva and sort of looking for one person, again, because of these profound PFS gains, to say, it's okay, that we've probably had enough, let's take a little break and continue the steroids. Yeah,
I think just to remind folks that this is a concurrent chemorads given in the best way is a tough regimen.
Yeah, absolutely.
Looking at that Nasser Hannah trial in the HOG group, sort of a real world statewide or beyond regimen, I believe the number was that just getting concurrent chemorads alone, 1/3 of the people were hospitalized due to various adverse effects. Fevers, pneumonitis. So it's a tough regimen. but in my mind, very justified because of the goal here. If we can cure folks, and then now hopefully with the addition of Durvalumab, cure even more people, it's worth pushing the envelope.